Welcome to another Urowebinar. Today we will have the webinar to fuse or not to fuse on fusion biopsy, presented by expert urologist Dr. Jochen Walz and expert radiologist Dr. Jurgen Fütterer. We will start with the presentation of Dr. Jurgen Fütterer.
Thank you, Jochen, for the introduction. So my part will cover the part of the MRI of the prostate, and Jochen will mainly focus MR-targeted biopsy. So as you all know, prostate cancer is quite common. Last year we had more than 240,000 new cases of prostate cancer, and the treatment options range from active surveillance, doing severe and actually doing nothing, to whole gland treatments like surgery and radiotherapy. And for all these indications we can perform imaging, and if you go back 15 years ago, the main question from urologists was, is there a stage T2 or T3 disease, so looking at local regional staging. And more we are adding indications for MRI to our daily routine. That means we want to detect cancer, so patients with a rising PSA and a negative biopsy. Localize cancer, if you think about, for example, focal therapy or targeted treatments. Characterization of the lesion, for example, active surveillance. And also we can use it for assessment of recurrent disease, or even uses MRI information to perform an MR-targeted biopsy. So what we've seen in the last 10 years is a paradigm shift by MRI. So we, instead of staging, we perform it for detection, finding significant cancers within the prostate. What we also notice is that we are performing more and more MRI-targeted biopsy instead of using the truss-guided biopsy. With the addition of the sequences like diffusion and perfusion, we came up with a simple multi-parametric MRI of the prostate, and we don't use any anorectal coils, which is used for signal reception close to the prostate, or MR spectroscopy. So what is MRI of the prostate? It consists of T2 with imaging, gives information about anatomy, diffusion with imaging, information about biology, and dynamic contrast enhanced MRI gives information on vascularity. And in some cases, MR spectroscopic imaging is performed, which provides metabolic information. So T2 gives information about anatomy. It's a cornerstone of imaging, so it gives us all the information about the location of the lesion within the prostate. However, not every dark lesion which is visible is a cancer, so not every dark spot on the T2 is a cancer. So in this case, there's a lesion in the left peripheral zone, which is a dark homogeneous lesion, which corresponds to cancer. However, you look at the transition zone, which is internally located, you can actually appreciate the BPH nodules, which may mimic cancer. So we have to add other techniques to improve ourselves and improve the specificity by using, for example, diffusion with imaging or contrast enhanced MRI. So in general, we are afraid, of course, of having post-biopsy hemorrhage artifacts, especially when a patient underwent truss-guided biopsy or MR-targeted biopsy. This may mimic also the cancer. So in patient with staging, we wait 4 to 6 weeks. However, in patients in which we have a high suspicion of cancer, in general, we don't wait for the MRI. So what about the normal anatomy? So we have the base of the prostate with the bladder, the seminal vesicles. If you go one level down, we have the central zone. The central zone is always symmetric, quite often confused for cancer because it has a low signal intensity area, which is symmetric, sometimes also called the bunny ears. They also can be show restricted diffusion on the ADC map, but based on location, you can differentiate between a cancer and a non-cancerous area. The peripheral zone in general has a higher signal intensity compared to the central part of the prostate, so the transition zone, which is located over here. The inner part of the prostate, quite often it's inhomogeneous due to BPH nodules which are located in this area, and the peripheral zone in general is much higher in signal intensity compared to the transition zone. The anterior fibromyalgia stroma is also very important, which is located anteriorly from the transition zone. So this is a very dark signal intensity, dark area, which in general shouldn't enhance after contrast injection. If that's the case, you have to be careful, because that could still be a cancer which is invading into the anterior fibromyalgia stroma. And of course you have the urethra over here, which is located at the level of the sphincter, and the axillary ducts, which are located over here, which you can follow to the urethra. So diffusion next to T2, I think in my opinion, is the most important sequence in the MPMRI of the prostate. It has a very high specificity of aggressiveness. So in this case, if you go back to the T2, we saw a dark lesion in the left peripheral zone. However, the downside of this kind of technique is prone to cystability artifacts. That means if you have gas in the rectum, the image could be distorted. And for example, if you see a tumor over here, it may actually be over here because of the distortion. So you have to be aware of that. Several authors have shown that there is a negative correlation between the ADC value. If you measure the ADC value, if you go back to the ADC map here, if you measure the value over here, the lower the ADC value, the most likely you're dealing with a more aggressive tumor. Perfusion, there's a huge debate going on if we have to use perfusion anymore. Do we need that to make the diagnosis? In general, in 5 to 10% of the cases, you need perfusion to enhance your diagnosis, because we are talking about elderly patients with quite often they have hip implants, and that means that the diffusion with imaging may be hampered due to the artifacts of the iron, which is in the hip implant. So DC may be helpful, has a very high sensitivity, so every lesion will enhance. Also the benign lesion, like in this case the BPH, which is centrally located here, shows Pokorny enhancement, and this is typically seen in BPH nodules. It's also essential in recurrence detection. So quite often, if you have a patient coming back with a PSA relapse after, for example, external radiotherapy, perfusion will give you the answer to find the lesion and localize the lesion. However, it's very sensitive, and also the downside is that it has a very low specificity. There's limited standardization. You need tools for that to analyze those contrast enhancement curves, and of course there are costs involved using contrast agents. And mass spectroscopy, I don't want to touch too much time on that, spend too much time on that. In this case, you need an underwriter coil to get enough signal-to-noise ratio. So to have enough signal, then you have to put an antenna next to the prostate, and that's the underwriter coil. And this way, you can get your diagnosis. However, it's time-consuming. It requires an underwriter coil. It also requires expertise, which is quite often not available in a lot of hospitals. So what's important, like buying a house, location, 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 especially if you talk about MR target biopsy using a transfusion system, location is very important. Location information is very important. Of course, aggressiveness, if you talk about active surveillance, tumor volume, if you think about focal therapies, of course, staging T2 versus T3 within or outside the capsule or invasion into the seminal vesicles, and note the bone metastases are also important information you need from the MRI. So if we look at the localization accuracies using MPMRI, there are actually no prospective multi-center studies yet available. We're analyzing now data from multi-center study in which we applied all those techniques, T2, diffusion, perfusion, spectroscopy was part of the trial. And what we found is that the ADC, so the diffusion with imaging, has the most promising result so far. So if we look at the peripheral zone and the transition zone, the highest area in the curve is being obtained using diffusion with imaging compared to MR spectroscopy or even perfusion MRI. So that also strengthens or gives arguments for only using T2 and diffusion, of course. If we look at the combining all the information from the MP-MRI to find the lesion within the peripheral zone or in the central part or the transition zone. ADC alone has an error in the curve of 0.92. Adding all those other techniques only adds minimal to 0.94 for the peripheral zone. So in other words, ADC combined with T2, we already have a very high likelihood of finding the significant cancer within the prostate. PI-RADS, only want to shortly touch on that. Version 2 since last year, I think since 2015 was developed, 2016 published, with 5-point assessment categories. If you have PI-RADS 1 and 2 lesion, clinical significant cancer is highly unlikely or unlikely to be present. And the question is, of course, should you do a biopsy or a MR target biopsy with a PI-RADS 1 or 2? We have the intermediate and the 4 or 5 lesions, in my opinion, should be biopsied. With the PI-RADS 3, there's still discussion going on whether to biopsy or not. What's clinical significant? If you look in this systematic review, we found that if you look at the definition in several papers, there's a diffuse representation of what is clinical significant. So every study uses different categories. So they use different endpoints. So one study is using Gleason 3+4 or higher. Another study is using PSA density plus Gleason score plus tumor length, etc. So it's quite difficult to assess what's clinically significant and how can we compare all those studies. So in the PI-RADS, we define clinical significant cancer as a Gleason 7 or higher with a 3+4, including a 3+4, a volume on MRI of 0.5 cc, or if you see extrahepatic extension. So in the version 2, we focus mainly on T2 and diffusion. As mentioned before, perfusion, so contrast-enhanced MRI, is getting less and less important. So for the peripheral zone, the diffusion-weighted sequence is the most important one, and for the T2, the transition zone, the T2 is the most important sequence. DC can only alter the final PI-RADS score in certain cases. So this is an example in the peripheral zone. Diffusion is dominant sequence. So if you have on diffusion a score of 4 and T2 is a 2, diffusion will still be the highest ranking score, so the final PI-RADS score will be a 4. Sometimes you're doubting, and if you have the PI-RADS 3, only the perfusion may alter the final diagnosis and upstage it from a 3 to a 4. For the transition zone, the T2 is a dominant sequence. So no matter what diffusion or perfusion shows, if you have on T2 a 4, the final score will be a 4. Only if you have a score of 3 on T2, the final PI-RADS score can be altered by, in this case, by diffusion. If you have a diffusion 5, the final score will be, instead of the 3, a 4. As an example, there's a diffusion-weighted sequence with the ADC map and the high B value on the right side. On the left-hand side, in the right peripheral zone, there's a dark hot spot on the ADC map. We don't actually measure the ADC value, but if we measure the diameter, it's less than 1.5 cm. It's high in the high B value, so very suggestive. So in this case, the score is a 4 in diffusion, and the final PI-RADS score will be a 4 because it cannot be altered by T2 or perfusion. Perfusion, mentioned before, it's a binary, so it's either negative or positive. And only if you have a focal enhancement at the same location as a lesion on T2 or diffusion, it's positive. So what currently are the facts? If you look at the meta-analysis, 14 studies, if you look at the PI-RADS 2 using the dominant sequence, the sensitivity and specificity of finding a significant cancer is around 82%. So what sampling technique? There are several techniques available. In-bore biopsy, I think, is only being used in selected cases. Currently, most people are using MRI fusion or using cognitive biopsy with the results on the end here, 71% for the in-bore biopsy, 59% on average for the trus MR fusion, and cognitive reveals around 54% of the lesions, of the significant ones. So if we compare, for example, inbore with fusion, MRI targeted biopsy in general is superior overall if you compare it with the cognitive targeted biopsy. However, if you have lesions more than 1 cm in diameter, you preferably perform a fusion biopsy rather than an inbore biopsy. And that's also very logical, because the 1 centimeter lesions, quite often if you see them on MRI, you go back to the trus fusion system and you see the trus image, most likely you will recognize the lesion on the trus image. With that, I want to hand over the microphone and presentation to Jochen.
Okay, thank you very much, Jurgen. Very nice. I just need to start my presentation. I hope you can see that all nicely. I will just okay, now I'm good. So we were talking about the basics of MR, and now we are talking a little bit more about fusion itself. Jurgen mentioned already a little bit. What we really need is a reliable and standardized transfer of the information from radiology to urology. That is the cornerstone of the entire pathway. We cannot really get this information across to urology, then it will not work. And if you receive reports like this here on the right-hand side, where you have 21 words and 5 lines, it's just impossible to get this information across, to know where the lesion is, and to do then any clinically relevant decision making with this. So you need a standardized report, as shown here on the left-hand side, which gives you, or could give you, some sketches where the lesion is highlighted, so you can identify the area where you might take a target out of it, and you will get detailed information about these areas that might be positive or negative according to the sectors that are identified inside of the prostate according to the PI-RADS recommendations and standards. And with such a report you can work, and ideally you'd also get some representative pictures of the prostate where you can then look at the MR pictures itself in order to familiarize with the location of the lesion you might go for a target. But this is the cornerstone. If you don't have such a report as shown here on the left-hand side, then you will be unable to work with this data. And then, of course, the question is, how can you get to the target? How can you biopsy the prostate and the lesion that is suspicious? Well, for this, you have 2 options available. You can do a software fusion, or you can do what we call a cognitive fusion. And I just would like to show you a short outline how a cognitive fusion looks like. Again, this is a sketch you might receive from your radiologist. Of course, this is a big lesion that is not very difficult to get it. You might even get it with a randomized biopsy, but it's just to show you how it could work and how you could work with it. So you identify the left-hand side where the lesion is, mainly at the mid part, and then ideally you have also a look at the pictures itself, eventually with your radiologist, and then you really try to localize where it is, and be careful on the sections you might have in the actual sections here. They need to be perpendicular to the posterior wall of the prostate in order to simulate the sections you can get with the ultrasound probe, either an end-fire probe or a side-fire probe. Sometimes they are really oblique, and in such cases a lesion that is shown here at the posterior side will be in fact, if it's shown at the anterior side, at the apex and no more at the mid part. So this is an important information. But here now you can identify the lesion on the MR, and then you can use landmarks inside of the MR picture, such as cysts or BPH nodules or the urethra or the borders between the peripheral zone and the central zone or the transition zone, in order to really localize the area you're interested in. And as Jurgen mentioned already also, there are sometimes, or in many cases, you see a hypoechoic area inside of the prostate in the ultrasound picture, and this is then very often the lesion you're looking for in the MR, and this is then where you would take your targeted biopsy out of if you're doing a cognitive fusion. If you do a software fusion, here just some technical informations. Well, you need to have something that tells the system where you're looking at with your ultrasound picture and where you are virtually in the MR picture. And for this, you need 3D navigation devices. And in most cases, It is done either with an electromagnetic field, where you have a sensor on the ultrasound probe, and then this sensor tells the system where you're looking at with the ultrasound probe. It can be done mechanically, so you have articulations fixed to the ultrasound probe that replace on this electromagnetic sensor and tell the system where you're looking at. And then you can do it also image-based, which means you have an ultrasound picture, you have an MR picture. The system knows how the prostate looks like in MR and in ultrasound, and then fuses the shapes of the two imaging tools together. And this then is independent of any mechanical or 3D navigation. And in theory, you can also use optical navigation or acoustic navigation, but they are less used with this purpose, for this purpose of a prostate biopsy. You have different ways to fuse the pictures, to overlay the pictures. You have what we call the rigid fusion, where you just overlay the MR pictures with the ultrasound pictures, not adjusting for any deformation you might have, especially with the ultrasound picture when you're pushing on the prostate with the ultrasound probe. And then you have what we call the elastic fusion, where these changes in shape are taken care of, and this, at least in theory, is supposed to be more precise than just rigidly overlaying the pictures. At a certain time point, you need to tell the system where the prostate is inside of the MR picture, as well as where the prostate is inside of the ultrasound picture. And for this, you need to do a segmentation, a delineation, so you need to show where the prostate is, and this needs to be done either manually or semi-automatic. So you just make a circumferential line around the prostate on several cuts from base to the apex in order to show the system where the prostate is. You also highlight the areas of interest where you will, or where you're aiming the target for, and then you do the same with the prostate in the ultrasound picture. And with this approach, the system knows now where the prostate is, and they can start to correlate the pictures together. You can also use 3D markers that are visualized with the MR pictures and that are also visualized with an electromagnetic field, and then you do the MR with the marker already stick to the skin of the patient, and then the data you generate with the MR picture right before biopsy can then be used to navigate inside of the prostate. And for this, you don't need any segmentation or delineation, really speeding up the process and rendering the process less prone to systematic errors. Software fusion has some limitations, that is clear, and I was just talking already about the systematic error. If you do something in the entire process, especially of the process of segmentation, then of course the fusion will not really work. And the more steps and the more complicated it is to do, the higher the risk that you have a systematic error in there. And this error probably will lead then to misalignment. As you can see here on the right-hand side, the prostate actually is here, but on the MR, superimposed MR picture, the prostate is shown here, so there's really no correlation between the MR picture and the ultrasound picture, and actually the lesion is down here. So if you would take a biopsy of this one here, then probably you would miss your target. And especially with the different fusion systems out there, you should really not overestimate the capabilities. I always consider these systems rather being like a GPS system when you're driving into town, a GPS system that shows you where the street is, but if you want to find the right house, you need to identify the house number yourself. So it brings you in the right area, but then again you need probably to look for these hypoechoic areas where the lesion might be localized, and then you rather go for this hypoechoic area here than instead to targeting really strictly the area that is shown in the MR fusion. So use your brain despite the fact that you use very sophisticated software and technology. And then we have the in-bore MR guided biopsy, where we do something what we call MR fluoroscopy. So we have MR real-time guidance of the needle and as well as real-time targeting. But for this we need specific material that is usable in the MR environment, especially like in the strong magnetic field, and this is associated to cost, to time, investment, as well as with this together then to quite a use of resources. And the question is also how we can take additional randomized course if they are indicated. As Jurgen said already, I'm not sure that this is the way to go for every patient, but some patients might be good candidates for these in-bore biopsies. So now I would like to really have a look where to fuse or if we need to fuse systematically or not. And here are some studies that compare the cognitive with the rigid fusion and the elastic fusion. And in this study here, they showed an advantage for the software fusion over the cognitive fusion. But there are other studies that did the same. They could not show a statistically significant difference in the detection rates between cognitive fusion and software fusion. And it is of note that this study is coming here from a center of excellence in Lille in France. They have a long experience with MR-guided biopsies, and probably you can conclude from this data here that if you have a good experience with both approaches, then probably fusion biopsy is not really necessary. Here again, another study compared cognitive fusion with software fusion, not showing an advantage regarding the detection rate, with the exception of those cancers that were of small diameter. And it makes sense. These are definitely the lesions that are the most difficult to identify and to target, as well as the lesions that were localized anteriorly in the prostate. And this makes also sense. The more anterior you are, the further away you are from the prostate probe, and the more you're likely to get out of range, not being at the right area. There was just recently published a thoroughly done meta-analysis comparing the different targeting approaches, cognitive, software, and MR in-bore, and they had a look at the sensitivity for all cancers, for the detection of all cancers. And if you compare cognitive with software, the difference was not statistically significant. It was significant when comparing cognitive with MR in-bore. Jurgen mentioned that already. And it was not significant if you compare software fusion biopsy with in-bore biopsy. And when it comes for the detection of significant cancers, then actually there was no statistically significant difference in the sensitivity to detect the cancers with all three different approaches. So when is software fusion especially helpful? As I was showing you, it is helpful for anterior lesions and smaller lesions. Unfortunately, we do not have a cutoff available from which on we should rather use software fusion. It is also useful if you have only a limited transfer of information from radiology to urology. For example, if you do not have the possibility to sit down with your radiologist and to have a look at the pictures together. In such a case, the radiologist could send you the marked pictures with a DICOM in a DICOM format, which could then be integrated into the fusion system, and that might help to render the entire clinical pathway more feasible. It is with this also necessary or useful if you have limited experience with MR reading as well as ultrasound imaging. It is also useful if you want to render it foolproof, if, for example, your residents are doing the biopsies and you want to make sure that they are able to do this, then maybe a fusion system is also of interest. And then it is also of interest if you need a documentation, if you really want to know where the biopsy is taken, and some of the systems provide you with this possibility to really register and to save and to store the information where the biopsy was taken. At the end, I would just like to have a short look on what we can expect from targeted biopsies, and I would just like to have a look here at the detection rates and the significance of cancers we might find or not find. When you look at the detection rates, we need to differentiate the initial biopsy from the repeat biopsy, and these here are only studies that systematically compare a targeted biopsy with a randomized biopsy in the same patient done at the same time point. And if you look at the initial biopsy, you see that the randomized biopsy had a higher detection rate than the MR-targeted biopsy, meaning that if you would only do the MR-targeted biopsy, you would miss quite a number of prostate cancer cases. In the repeat biopsy setting, the situation is completely switched. Now here, the targeted biopsy is on the left-hand side and the randomized biopsy on the right-hand side. And you see here that if you compare targeted with randomized, then you have a higher detection rate in the repeat biopsy setting. That makes sense. You did a randomized biopsy already once, and it did not work, so why should it work in the second time? So change the strategy and switch then to an image-guided approach, and this will then increase your detection rates. And this approach is also supported by the EAU guidelines as well as the AUA and the SAR consensus recommendations. So if you have a patient with a clinical suspicion of prostate cancer despite a negative biopsy, then definitely this should be done with an MR guidance if a high quality MR is available. A word also on the cancer significance. Jurgen was quickly touching on that. It is important to note that the cancers you find or the information you get about the cancer with a targeted biopsy and a randomized biopsy are quite different. You do a targeted biopsy, per definition it will be a centered core right in the middle of the lesion, and if you do a randomized biopsy, very often it's only the periphery. Being a centered core, the targeted biopsy will have way more cancer involvement per core, and with this have a higher likelihood to find high-grade disease if it is present. And this is not the case with a randomized biopsy. Here you're lucky if you found the cancer, but you would not expect and you cannot expect that you have a true interpretation of the grade as well as the true size of the lesion. And this is also evidenced here on this slide. Again, these are only trials that systematically compare targeted with randomized biopsy, and you see that the targeted biopsy is associated to higher cancer involvement per core, as well as a higher likelihood to find high-grade disease if it is present. And this is the reason why the MR-guided biopsy is also quite interesting for active surveillance. If you do an MR-guided biopsy in patients that are candidates for active surveillance, well, the MR-guided biopsy will upgrade, reclassify up to 35 to 40% of patients due to the better evaluation of the tissue and of the cancer lesion. And this is also supported by the EAU guidelines. But we need to be careful if we compare targeted with randomized biopsy that we classify all cancers that are classified to be non-significant based on randomized biopsy to be really non-significant. We know that, for example, the Epstein criteria largely underestimate the true extent of the disease, the true grade of the disease, and if a patient fulfills the Epstein criteria, you have basically a 25 to 30% risk of being upgraded or having even advanced disease. So a comparison between randomized and targeted biopsy regarding the cancer significance depends very much on the definitions. And here just an example how the definition might have an influence on this. This is a small lesion, 5 millimeters in diameter, Gleason 3+3. If you would apply to a targeted biopsy the criteria of Epstein, not more than 3 millimeters, well, this would be a significant cancer because you have a 5 millimeter involvement. But in fact, it is only a 0.06 cc cancer, Gleason 3+3, definitely not significant. So here the risk is definitely overinflated, overestimated due to the application of the wrong criteria to the wrong diagnostic approach in this setting. And this is also summarized in the meta-analysis I was just showing you. The author said here, I just would like to read it to you, the heterogeneous usage of definitions for clinical significant prostate cancer is a major concern for this current meta-analysis because most definitions have their origin in the systematic biopsy setting, such as the Epstein criteria. They are based on cancer core length and number of positive cores and therefore might significantly overestimate the number of detected clinical significant prostate cancer in a targeted biopsy setting. In conclusion, we can say that if we want to make the MR pathway work, we need to have standards, training, respective recommendations, and especially high-quality MR. We really need to know what we're looking at and how to do it. The cognitive fusion seems to be comparable to software fusion if it is in experienced hands or done in experienced centers. And software fusion is especially of interest for small and anterior lesions. For the time being, MR-guided biopsy is not better regarding the detection rates than randomized biopsy if it's done at the initial setting. For the repeat biopsy, it is clearly recommended by almost all scientific societies. Targeted biopsies give more precise information about the true grade and the true size of the disease, and this is especially of interest for active surveillance, but statements regarding the significance between the two approaches very much depend on the definitions. So from my point of view, we cannot really formally conclude here. And this was my presentation. Thank you very much. And now we are very happy to answer questions. And we now need to see if you submitted already some questions. Jurgen, do you want to come back on the microphone and the picture? Yeah, perfect. Thank you very much. So the question is, what is the recommended interval between an MR scan and the biopsy? Well, I would not expect that there's a lot of changes in a time period of maybe 6 months or a year. because prostate cancer is a disease that is slowly progressing and probably will not have, at least in MR pictures, substantially changes during this time period. And the question, of course, is of special importance and interest for active surveillance, where we might do repeat MRs at a certain time point just to see if lesions that you might see did change over time, and to organize new biopsies. And the question is, do we need to do an MR every year, or do we need to do it every 2 years? And probably every year is a little bit too often, because there will be not too many changes in there. But we do not currently have specific data on sequential MRs where we can really explore this question, how fast prostate cancer might progress in MR images. Jurgen, do you have more information on that?
So actually, we don't have no real data or what the follow-up should be. For example, what we do in clinical practice, we advise to wait at least a year and use PSA as a marker. If the PSA rises very quickly, of course, then you could redo the MRI much earlier. But in general, we wait 12 months. If we talk about active surveillance, then there is some evidence that MRI shouldn't be done every year, rather more than 2 or once in 3 years, because the interval cancers will be picked up after around 3 to 4 years in general.
I agree.
I have one question here. Do you think whether transperineal fusion biopsy is superior to transrectal? I don't have too much experience on that. Perhaps you had that, Jochen, on transperineal fusion biopsy?
Actually, I don't think that there's a lot of differences between the transrectal approach and the transperineal approach. Actually, the transperineal approach often needs a little bit more sophisticated anesthesia. It can be done under local anesthesia, but sometimes it's done in sedation, sometimes even under general anesthesia. So I would really, you need to weigh the advantages, the disadvantages. The beauty of the transperineal approach is that you have an easy way to really document where you took the biopsies, which is a little bit more complicated if you go for a transrectal approach, where the needle trajectory and the position is a little bit more difficult to really to file inside of a picture. And most of the fusion systems we have available currently that do it transperineally have a nice way to really register and show and where the biopsies were taken, where they might have been positive afterwards, to give you a sort of a cartography, a map of the cancer inside of the prostate, which is then of course interesting for any treatment you're planning afterwards.
And there's always also discussion about the rate of the sepsis rate, transrectal versus transperineal. So
yeah. There's another question regarding active surveillance. Would it be reasonable to do an MR fusion biopsy up front? That is the question. The question is up front. I would expect that the patient is included into the active surveillance protocol, probably based on a randomized biopsy, and then you think about really doing active surveillance of this patient. What I personally are doing, I go for a confirmation biopsy during the first 6 months, and only after this biopsy I really consider this patient a candidate for active surveillance if this new biopsy confirms what I would like to have, like a small volume cancer, low-grade disease. And I think indeed at that time point an MR fusion biopsy or an MR-guided biopsy is of special interest, because this is then really the possibility to get most out of the system and gives you most information about the cancer characteristics and helps you really to select the low-risk patient for active surveillance and sort out those patients that have a higher grade disease or high volume disease and shift them to active treatment. So I think this is indeed the most interesting use of MR right now in our daily practice, because it really changes the management of the patient. And I would rather go for an MR at inclusion for active surveillance and way less for the follow-up. if I need to choose and if I need to position it somewhere with some priorities. Jurgen, what do you think?
Yeah, from the several studies we know, for example, the previous study, we know that around 25 to 30% of the patients who opt for active surveillance and who get an MRI and an MRI target biopsy will be upstage, so will not be eligible for active surveillance. So I think quite often MRI is being recommended before inclusion for active surveillance. And that's done more and more in our clinical practice.
But we need to be very careful if we use targeted biopsies, and as I was showing you, and we apply the classical active surveillance criteria to these targeted biopsies, then we will avoid, or we do not active surveillance in many patients anymore, because again the risk is inflated and we do poor clinical decision making in this setting. And unfortunately, we do not yet have clear, accepted and validated criteria for active surveillance or non-significant disease based on targeted biopsies. There are some suggestions, but they are not generally accepted, and we really need to be careful, especially the number of positive cores. Of course, if you have a lesion, you take 4 targeted biopsies out of this lesion, you have 4 positive cores, he is no more fulfilling the Epstein criteria. This is complete nonsense, of course, but some do it, and we need to be careful how we select them patients when we use targeted biopsies.
That's a very good point. I have a question here for a patient with a negative first biopsy and persistent suspicion for prostate cancer. In the repeat setting, do you recommend only MRI target biopsy or both MRI targeted and systematic biopsy? Perhaps Jochen, I already see that you want to answer, or
you can go ahead. I will give my answer afterwards. Go ahead.
So what we know from literature, also from our own experience, that if you have a patient with rising PSA and negative first trust biopsy session with 10 or 12 cores, in general we only perform MR target biopsy of the lesion rather than sampling the entire prostate. If you look at the comparison between trust guided biopsy versus MR target biopsy, I think the yield is much higher, significantly higher compared to the trust approach rather than doing MR targeted biopsy.
My answer to this depends very much on how confident you are with your MR data. If you're very familiar with it and you did your own validation studies, you had a look what the negative predictive value of your MR is, and if that is really high, then you might only go for targeted biopsies. But I would state for the time being that this is only the case in very few experienced centers. Nijmegen, of course, is part of that. But all the other centers, the highest detection rate and the highest diagnostic reliability you will get if you combine both together. You do your targeted biopsy together with the randomized biopsy, and this gives you a maximum of certainty that this patient had a good evaluation and that this patient has prostate cancer or not. And if this approach then is negative, I think you're quite comfortable that this patient does not need, for the time being, more sophisticated follow-up than maybe PSA and then a re-evaluation a few years afterwards, depending very much, of course, on how the PSA development is afterwards. What you can also do in this situation is, of course, you can use genetic markers, which are very popular in the United States and way less popular in Europe, but probably due to the fact that in Europe we are right now very much more into MR and imaging than the genetic testing.
I think the other thing is that if you do these kind of MR targeted biopsy approaches, you always have to look back what the pathology results shows and compare it with the MRI results. In this way you can improve yourself and also have a kind of way, what is your NPV, what's your negative predictive value with your MRI? Because as Jochen already mentioned, the MRI quality may differ between centers. So it's very, very recommended to discuss that with your radiologist and get feedback on both sides to improve both of you.
That is a very important point. You really need to work together. You need to join up. You need to make a prostate cancer diagnostic team. And if you don't have a very close exchange between urologists, radiologists, and pathologists, you will be not able to improve what you're doing. And me personally, I'm sitting down with my radiologist 3 times a week, and once all 3 together with pathology to read the slides we have from pathology after radical prostatectomy as well as from MR. Really like to train ourselves and to improve and to see what we saw in MR and what we had afterwards. and this improves the performance of everybody. So this is an important step. There's another question coming up that is addressed to me. Do you defend doing MR fusion biopsy at the first re-biopsy, or would you rather prefer doing it after the second or third prostate biopsy? I think the answer is clear. As soon as you go for a repeat biopsy, this should be an image-guided approach. I was showing you the data. It is really striking. If you compare a targeted with a randomized biopsy, in the repeat biopsy setting, you have a higher detection rate. And I think it makes no sense in trying a diagnostic test at several occasions when it did not work at the first time. So as soon as you had a negative randomized biopsy and you have a strong suspicion that this patient might have prostate cancer, this is where you should switch to high quality MR. Jurgen, do you agree?
So, I have another question. What should be the minimal quality in terms of Tesla for a good target biopsy? If you look at the PROMISE trial, which has been published very recently, that was a study using 1.5 Tesla. They've shown already some promising results. Direct comparisons between 1.5 Tesla and 3T, because that are the field strengths we're talking about. 3T, of course, has the highest image quality because of the signal-to-noise ratio. But we also know that a lot of hospitals don't have the high field strength, so they have 1.5T Tesla systems. But we also know that with the newer systems, the image quality which can be obtained with those machines can be of very high quality. Of course, not comparable with 3T, but comparable with a high quality and diagnostic standard. So it's very important, if you discuss this with the radiologist, is that we have to ask what kind of system we have. Is it up to date? Has it the newest coil system? How do you assess quality? Do you use the European guidelines for MR imaging? And what about, for example, how many do you go to MR courses for interpretation of MRI of the prostate? And we also perhaps think about certification. But that's I think, very important questions. And if you have 1.5T system, which is high quality, I think that's already enough to do a high quality prostate MRI.
There's another question that is a question I also always like to address. That is, what about costs? Is it government funded in your country? Regarding France, where I'm working, it is indeed reimbursed by Social Security if you do an MR. But indeed, costs need to be really extensively considered in this setting. And I'm still a little bit, I'm not sure about that. Doing MR in all patients before the first biopsy, before any biopsy, is cost effective or is affordable. And of course, we have some cost effectiveness studies coming from Nijmegen that show that it is cost effective. But then we need to be very careful about these cost effectiveness studies. They use a lot of assumptions that are maybe in some countries realistic but will not be realistic in other countries. And then, of course, all the clear euro numbers you're using are very much depending also on the country. So you cannot transfer these cost analysis studies from one country to another. And this is indeed something that needs to be thoroughly explored in order to know that it's really feasible or not, and if we are doing a good job with our limited resources we have. Do you want to add something on that from your point of view?
I totally agree. So if you look at health technology assessment and compare it with different countries, every country has a different system. And so we got that comment, and what we now do is that we going to implement to do a first MRI and then do a biopsy. And then look after a year, what about the cost effectiveness and what is the benefit for the patient, because that's the most important, I think. Of course, costs are also important with the increasing costs in our healthcare systems. But because of these very good comments, we now implementing that together with the insurance companies to find out if this model is really also cost effective in real practice.
I have another question. That is, do you think that multiparametric MR has enough negative predictive value to cancel the biopsy if PSA is the only indication for biopsy? Well, I personally do not think so, but again, it depends very much on what the quality is, what the experience is, and if you did your own validations. So you indeed should go back to your pathologies, to your biopsies, and check what you saw, and you need to calculate your negative predictive value for your own center in order to know if you can skip a biopsy in a patient that has other indications for a biopsy and a negative MR. We just recently published a small study where all patients had a negative MR before surgery and they underwent surgery, and we could show that in these patients quite a high number of patients had indeed significant cancers. And especially we did also a quality evaluation, and we compared the expertise MR, the expert MRs with these coming from somewhere else, and we could show that if the MR is negative done by an expert, then there's a low likelihood that you miss substantial disease. You still might miss some small volume high-grade disease cancers, which are the most challenging cases, but you will probably rule out the presence of high volume high-grade disease if it's done by an expert. Jurgen, any comments on that?
No, because I think we have to finish up this webinar.
Yeah. So unfortunately, we're not able to answer all questions. There were a lot of them out there. Thank you very much for your participation and your interaction. I would like to thank you to participate. It was a pleasure doing this webinar. Jurgen as well. Thank you very much. And I just would like to invite you for the next webinar, which will be on the 23rd of February. Which will be on infections, and it's Florian Wagenlehner from Germany who will organize it, and it's the 23rd of February, 6:30 as usual, p.m. Central European Time. So thank you very much for your participation. Jurgen, want to make some comments at the end?
Thank you, Jochen, also for your participation.
Okay, great. Thank you very much. Bye-bye.